Good evening, all. On behalf of Eastern Melbourne PHN, Northwestern Melbourne PHN, and Dementia Training Australia, I wish to welcome everyone to the Demystifying Dementia Session 1, Recognising Dementia in General Practice. My name is Nicole Stark, and I'm the Events and Education Coordinator at MFIM. Now, before we begin, I would like to start with an acknowledgement of country. Eastern Melbourne PHN, Northwestern PHN and Dementia Training Australia acknowledges the Wurundjeri people and other people of the Kulin Nations on whose unceded lands our work in the community takes place. MFIN respectfully acknowledges their ancestors and elders past and present. In the spirit of reconciliation, Eastern Melbourne PHN acknowledges the traditional custodians of country throughout Australia and their cultural, environmental, and spiritual connections to land, sea, and community. We pay our respects to their elders past and present and extend respect to all Aboriginal and Torres Strait Islander people today. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Some quick housekeeping. All attendees will remain on mute throughout the presentation. And if you have any questions, please type any of those questions for our presenters in the Q&A box at the bottom of the screen, and these will be answered at the end of the presentation. A little bit about PHNs. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for those most vulnerable. MFIN and Northwest Melbourne PHN achieves this goal by improving access to existing services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. We thank you all in joining us for this valuable RACGP accredited education activity. Dementia is a term used to describe a group of conditions characterized by gradual impairment of brain function, which may impact memory, speech, cognition, personality, behavior, and mobility. Dementia is a significant and growing health and aged care issue. It is the second leading cause of death in Australia, with more than 400,000 Australians living with the illness. This evidence-based program has been designed to improve both confidence in clinical ability and attitudes to dementia care. This session will describe the stages and domains approach to recognising dementia in general practice. I'd now like to introduce our fabulous speakers. Dr. Marita Long is a speaker and lead GP educator with Dementia Training Australia. She graduated from the University of Tasmania in 2007 and has extensive experience in general practice. Dr. Long specialises in developing innovative workshops to enhance GPs' capacity in recognising and managing dementia with evaluations published in BMJ Open. Dr. Karen Savory is a Brisbane-based GP who works in clinical practice, residential aged care, and medical education. She is passionate about the education and mentoring of GPs, particularly in aged care and dementia. She works with Dementia Training Australia to increase GPs' confidence in the recognition and management of dementia. On that note, I will now pass the metaphorical mic to Marita. Thank you so much.
Thanks so much for that introduction. We're going to get Jenny, who's going to launch our slideshow for you guys tonight. Yeah, we're incredibly lucky to have Dr. Karen Savory with us tonight. She's an incredible medical educator and has loads of experience in aged care. So welcome, Karen. She's very lucky that she's in the nice warm north part of the country, whereas we're all freezing down here. So next slide, Jenny. So this is just a quick acknowledgement slide to say it's not just us who have developed this work. There's been lots of people who have come before us and contributed to the development of this work. If we go on to the next slide, we're not going to read those out. We'll send you a PDF and you can nut out those all those learning outcomes. But we'll go on to the next slide, which is really the bang for buck stuff, which is really where we like to begin with the end in mind. And that's really if you can leave this evening, really understanding that dementia is more than a memory problem. That's what we always think about dementia, but it is more than that. And also that cognitive assessment tools are not diagnostic tests, nor are they really screening tests. But we'll talk a little bit about that throughout the course of the presentation tonight. And just to say, look, in many situations, a GP is able to diagnose and initiate post-diagnostic care for people living with dementia. And when we're talking about dementia, for the purpose of this evening, we're really talking about Alzheimer's and or vascular, because they're the most common kinds. This doesn't mean you need to leave tonight thinking, oh my God, I've now got to diagnose dementia. Of course, it takes a lot of time of thinking about dementia, practice doing it, and of course there are always specialists that you can refer to and consult with. So we're not expecting after 1 hour tonight that you're all going to be experts in diagnosing dementia. It is incredibly complex, but hopefully you'll have a good framework to start the process going. So next slide, thanks, Jenny. So we always pop this trigger warning here. Most of us will know someone. If it's not a patient, we will know a relative who's traveled the journey of dementia. I had a father who died from dementia, and it always, you know, makes me feel a little bit sad. And I always think about my dad when I present. So just letting you know that you may feel a little bit sad or feel a little bit triggered, and to, you know, contact someone afterwards if you've got a colleague, a friend, family member, just to say that you have felt a little bit upset by tonight's presentation. And if we just go on to the next slide, Jenny, this is really about something we're all learning about. Dementia is a really contested space. It has a very strong advocacy group, which is really important because people with dementia are so incredibly vulnerable. So we try really hard throughout our presentations to use appropriate language. Sometimes we get it wrong. But thinking about how we talk about people with dementia. So we'll always refer to people living with dementia. We try to put the person, I guess, central, not the disease at the beginning. And DA, Dementia Australia, do have some great resources, which I really think are useful, even at your next clinical meeting in your practice. If you want to talk about some of the language, it's a really useful guideline to start thinking about how we use our words when we're describing people with dementia or talking about our patients living with dementia. Okay, if we go on to the next slide, thanks, Jenny. And this is where we have a bit of fun, hopefully. And I'm going to hand over to Karen now because she's going to lead us through a game, which some of you may remember, called The Price is Right.
And for those of you that do, you might remember that you had to rank things in order to win the prize at the bottom. Now, we're not going to give you a prize tonight, but we're going to look at 10 medical conditions. And if we move the next slide on, we want you to think about, and a poll will come up, which is the easiest condition to diagnose out of those 10. We'll give you a moment to read them. But which one is the easiest for you to diagnose? And Marita, what makes something easy to diagnose for you?
Yeah, I think it's things that have a kind of predictable pattern, so they sort of present in the same way, or I guess it's something that has a nice, easy test that tells you yes or no.
We'll see if we've got those.
I'm just going to give them another 10 seconds. Get your votes in, everybody. 765 432 and 1. So I'm ending the poll and sharing the results.
So yeah, looking like something with a test, something that's relatively easy. It looks like everybody's agreeing with you there, Marita.
Yeah.
So we might move on then to think about which out of those 10 conditions is the hardest condition to diagnose. So again, we'll give you a moment to think about that as that poll comes up. But as we're thinking, Marita, any thoughts about which one's the hardest to diagnose? Or what
Well, I
makes
guess it's
something hard?
kind of the converse, isn't it? It's when there's no sort of easy test, it can make it a little bit harder. But when things might have a gradual sort of progression, you know, they're a little bit harder to notice. Or when it's where people might have multiple things going on and multiple conditions that might mimic other conditions as well, you know, with sort of sometimes heart failure and COPD, sometimes it's hard, isn't it, figuring out, is it an exacerbation of their COPD or is it their heart failure or is it a bit of both? So, you know, there can be some mimickers that can make it quite tricky as well.
Okay, sharing results.
And fairly typical of most of these questionnaires that dementia is one of the hardest conditions to diagnose, which is why we're talking about it tonight. Let's move to the next thing. So we've thought about diagnosis, but what about management? So out of our 10 conditions, which is the easiest one for you to manage? And Marita, any thoughts about that for you?
Well, things that get better on their own, where you don't have to do too much. That's usually the
Nice.
best. Again, where there's a kind of clear post-diagnostic pathway. So, you know, we're pretty familiar with diabetes and there's lots of guidelines with diabetes. So it's often very sort of easy to start managing something like that, or something perhaps where we pack the person off to someone else to manage. might make it easy.
Okay, and ending and sharing results.
So again, there's a bit of agreement with you there. So things that are self-limiting or improve with antibiotics, or things with definite sort of guidelines, definitely are coming up as the easiest to manage. So out of those same 10 then, which is the hardest condition to manage? We'll give you a moment to think about that. And I guess it's the converse to what we've been speaking about.
Yeah.
Yes, the votes coming in very quickly this time.
Thought they might.
Yep. Okay, I think we'll close it off there. I think there's going to be a winner.
So the most difficult condition to diagnose and also the hardest one to manage. So out of those 10 then, which do you think is the leading cause of death in women? Because these 10 conditions are actually the top 10 leading causes of death. We'll give you a moment to think about it.
Coming in. Okay, and we'll finish it there and share the results.
And that's a pretty common spread, but interestingly, our hardest condition to diagnose and manage is also the leading cause of death in women. So dementia is still at the top of the list, and second leading cause overall, although whether that will get displaced with COVID, I haven't seen, but it's certainly right up there, which is why we want to talk about it. So yeah, I'll hand it over to you, Marita.
Great. So it's interesting, isn't it, that we have, the hardest to diagnose, the hardest to manage, yet it is the leading cause of death for women. So it's something that we all really need to get our heads around. And if you can go to the next slide, Jenny. Part of what we've done in developing this workshop is that we have done research, and basically part of what the research told us was that no GPs have really had any formal education or training in the space of dementia, which is why we do what we're doing, and that's why you're here with us tonight to learn more about dementia. So if we go on to the next slide, Jenny, just a little bit about the impact of dementia. As we've said, it's the leading cause of death for women. It's actually the leading cause of disability for women as well. It's still the second leading cause of death overall, but it's now the leading cause of disability for anyone over the age of 65. So when I come into my office of a morning and I look down my screen about who I'm seeing, I'm certainly seeing a lot of women I'm certainly seeing a lot of patients over the age of 65. So this is a lot of our going to become a lot more of our bread and butter in general practice. Interestingly, women are twice as likely to be diagnosed with dementia than men, and that's a whole nother topic on its own. You're just going to have to take our word for that. So for your female patients and for any of you who are female GPs watching us tonight, we're twice as likely as a man to be diagnosed with dementia. We're also diagnosed later, and we have a much faster trajectory than men. The other thing that I think is really important to think about, if we're not seeing patients with cognitive changes or with dementia, we're probably seeing a woman who's caring for someone, because women do most of the care of people with dementia, whether that's in the paid or unpaid context. And it's often for unpaid people a significant amount of hours per week. And that's actually a risk factor for dementia as well. So it's something to really think about. And with our female patients, we've left them behind a lot in terms of recognizing cardiovascular disease and stroke. And we don't want to do that with dementia, because there is, chance for us to be able to intervene. So could we go into the next slide, Jenny? And we're going to think about how we define dementia. And, it's a tricky one, because it's not just one thing, but we think about it as a progressive, a global, life-limiting condition that involves generalized brain degeneration. And part of the difficulty of it is it does affect people in different ways and has very many different forms. No two people, unfortunately, present the same, and that can be due to the type of dementia, the comorbidities they have, their natural resources, how well they're supported within their environment. That's going to make a difference as well. So if we move on to that next slide. Important to really have this as a take home. This was really challenging when I first started in the dementia space, that people die from dementia due to that deterioration of the entirety of their brain. So it impacts on body functions that are necessary to sustain life. And just onto the next slide. Jenny, and I might hand over to you now, Karen.
So yes, so as we've already alluded to, it's difficult to diagnose, it's difficult to manage, particularly if you haven't had any extra education around dementia. It's certainly not well understood, and that's amongst both the community and through the medical world as well. But it does impact more than just one person. So it's impacting families and communities, both that social and medical side of things. But we do know there are things that we can do to make a difference. And I guess we hope by the end of this webinar and the next one that you'll walk away feeling a bit more confident that there are things that can be done. But it is a terminal illness, and probably, although it may change, it's got about a 10-year prognosis, depending on how delayed that diagnosis may be. So it certainly is a terminal illness, and we need to be having those conversations about that much earlier than often what we do. Next slide, Jenny. So when we're using the term dementia, as Marita said at the beginning, we're mostly thinking tonight and our next webinar about Alzheimer's and vascular dementia, because we know if you know about those two dementias in particular in Australia, then that's going to pretty much cover about 80 to 85% of the dementia that you will see. But that umbrella term does also cover a few other things. So there is Lewy body dementia, which is important to distinguish, and we can talk about that a little bit later, just because of the medication, severity of medication effects with Lewy body dementia. Frontotemporal dementia often presents much younger, can have a lot more personality changes. If you lived in Africa, you might see a lot of HIV-related dementia. There certainly are the types of dementia that you will come across, but specifically tonight we're looking at the two most common forms in Australia.
Great, thanks, Karen. And if we go into the next slide, this is where it all starts to get a bit tricky. With mild cognitive impairment also, that was again a term that was pretty nebulous when I started out in dementia education space 10 to 12 years ago. However, it's gaining a lot of momentum now. And in fact, they feel that there's probably 800,000 to 1 million people in Australia living with cognitive impairment. So this is where you have a significant memory loss compared with your peers, with age-matched peers. But it is important to note other areas of cognition can be affected as well. Most people with mild cognitive impairment are going to work and play okay. They're not going to be too impacted upon, but there might be difficulties in doing more complex tasks. And I've certainly got a patient at the moment who's mid-50s who we started talking about memory because she was starting to get a little bit concerned and wondering if it was a little bit more than she should expect. And when we nutted out what she was doing in order to do her job, she's a very high functioning EA, and how she's managing things like her bills, she's certainly putting a lot of stuff in place to be able to do that successfully. So she's probably one of the patients I'll be keeping a very close eye on. To make a diagnosis of mild cognitive impairment, you do actually need to go under some thorough assessment. And we do know that out of these 800,000 to 1 million, as many as 10 to 15% of these may progress on to a dementia each year. Some people with mild cognitive impairment, that's just where they're at. It's going to stay the same. They're not going to develop a dementia. They're going to age along a trajectory the same as other people. Some people, in fact, it will be caused through an insult, through a medication, perhaps through alcohol, and they may get better. And then you'll get the some people who will progress on to dementia, which is about that 10 to 15%. Now, the reason this is really coming into the forefront now is because of this development of the monoclonal antibodies, which I'm sure you've all heard a lot about on the news recently, and the advent of blood biomarkers. So the ability to detect disease before someone necessarily has the symptoms of dementia. So this is going to be a real watch this space in primary care. If we move on to the next slide, Jenny, and we're going to just quickly touch on normal age-related changes, because this is part of the problem that people are aware. Most people are going to notice as they age, their memory is getting worse. They are having memory lapses. You know, they go down the street, they bump into a group of friends and they think, oh God, I can't remember that person's name. Or you're trying to tell your friend at work about this great restaurant you went to and you just cannot remember the name of the restaurant. It's on the tip of your tongue, can't get it out. That's normal memory change. We also have some slower processing speeds, and these all start to happen, believe it or not, at about age 25, but our skills, life skills and experience tend to compensate. We can work and play okay with our normal age-related changes. It can be frustrating, but it's not having any significant functional impact, and it's usually just that we're aware of it. But if someone comes to you to say that they're noticing this, we know from people living with dementia that they often say that they bring up memory change and people say, oh no, that's normal. We all go through that. And yes, we all do go through these age-related changes, but I would encourage you to just dig and delve a little bit deeper to see if it could be more than that. So if we go on to the next slide, thanks, Jenny. And I'm just going to start off by talking about how we're going to introduce these frameworks for you to work on so that you've got a starting point if someone presents with a memory concern about how you might explore what else is going on. So this is our first framework that's called the domains of dementia. And so it's really looking at the five areas that can be affected. So the first is cognitive decline. So of course, what we're familiar with is memory. So most people will notice some memory change in terms of short-term memory first. But it can also be things like higher level decision making. So memory might be a little bit more intact, and they might actually have lost the ability to plan, to sequence things out well. It might be that they're having trouble following conversations or following plots in a movie, or unable to really keep up with reading books. They keep losing their place in books. It could be poor decision making. The next domain is the functional area. So there has to be some sort of impact on function, and this is where people start to struggle perhaps to cook. Someone who was the family cook, had cooked meals all their lives for the family, was all of a sudden struggling to remember the steps to be able to cook anymore, or that inability to be able to remember how to send an email, or getting an email and a text confused. Or it may be that they can no longer use the oven or the stove or the washing machine or the lawnmower. So there's something that's really impacting on their ability to function. The psychiatric symptoms are a bit of a tricky one again, because if someone has that insight that things are starting to change, of course it can make them feel anxious or depressed. So while someone might present with anxiety or depression, it could be the sign that there is something else going on as well. We know that depression can be called a pseudo dementia because it does slow down our thinking, and our memory can have those impacts also. But we also know that probably up to 50% or more of the people who are diagnosed with dementia at some point in time might have some delusions. Common ones are, ones around infidelity, or people moving things or stealing things because they can't find things anymore. And hallucinations can be quite a prominent presentation, or these can come throughout the course of the illness as well. Behaviour changes can happen very early on, where we see people starting to withdraw from things, becoming isolated, no longer wanting to go to bowls, or no longer wanting to go to bridge or out to restaurants, because they're just finding it very hard to manage the environment or the contact with people, or forgetting how to do things is becoming very stressful. Or we can see behaviour changes later on in the course of the illness, where it might be as a response to an unmet need. So if someone was constipated or in pain, they might shout out, yell out, because they can't verbalize what's going on. Or other times we can see some changes with people perhaps getting lost, or wandering, hoarding things. There can be very many varied behavior changes that are associated with having dementia. And then the physical decline, again, some of that will come on very early, where people can get some dyspraxia, so some difficulty with using implements or tools, some slowness in their gait perhaps, and then again later, where we're seeing the really end stages, where people are having problems with their mobility, their swallowing, their continence. So they're the 5 domains that we're thinking about. And these are a good way to think about how you might take a history to nut out what else could be going on when someone presents with some memory change. So if we go into the next slide, I might hand over to you, Karen, to talk about our stages framework.
So we've got the domains, so that's our five domains that get affected. Our next framework is the stages. So it's really just a way of thinking about how a person living with dementia might progress as the disease progresses. And they're not one day is stage 1 and one day is stage 2, but it is a progressive change over time. But stage 1 is really when people are still living at home. We certainly have that, what we think of often when we're thinking about dementia, as far as the memory loss, the repetitive sort of questions, starting to lose a little bit of function and starting often to lose interest in hobbies, or becoming more withdrawn, or some of those early behaviour changes that Marita talked about. Stage 2 is really when those care needs are escalating, so often needing a lot more assistance from family if they're at home in the community still, or even if they are, even the families often find it quite difficult, and often around this time people will end up requiring more care, and that may well be in residential aged care. And we certainly see that progression of both cognitive deficits as well as function, and sometimes that behavioural changes is actually what families find most difficult to deal with. If somebody is out at night or up often, or perhaps wandering out into the street where it might not be safe, that often drives some of those changes into residential aged care. Stage 3 then is really that becoming more end stage, so that quality of life is diminishing, the ability to really do anything independently is essentially gone, often needing either chair-bound or bed-bound, perhaps some more of those behaviours where that ability to communicate your needs is becoming much more difficult, and certainly that physical decline with swallowing and mobility. And we do note it's stage 1, 2 and 3 rather than mild, moderate and severe, because nobody thinks the diagnosis early on is mild. So we've used the terms 1, 2 and 3 instead. If we move on to the next slide, we'll put those two, the domains and the stages together, and you can see this really brings it all together. So as cognition and function gradually drops together often, They tend to go hand in hand, so they progressively decrease over the time. Those psychiatric changes can really occur at any stage through the disease process. As Marita said, it might be right at the beginning with diagnosis, or it may actually be further on into the disease. Behavioural change, again, as we said, we sometimes see those early apathies or withdrawal type behaviours. And as we go on, it becomes more the changed behaviours because of difficulties with communication or things in environment or perhaps delirium or other things that might affect it. But what we do know is if we can diagnose people in stage 1, that's very different to if we wait until all those lines intersect and cross around 2 and 3. So much better for somebody to be diagnosed earlier where they potentially have some say in what's going on than wait until they've had a fall or there's a catastrophe at home or it's all very messy, and at that point a diagnosis is often being made. So it's nicer not to be in that messy stage.
I don't know about you, Karen, but I think this kind of graphic representation is a really useful tool to gently talk to people who are diagnosed with dementia, but particularly the carers, about what that trajectory may look like. And we know it is very different for everyone, and this is sort of an overall look. But I think before I did medicine, I worked as a maternal and child health nurse, and a lot of our work was offering families what we would call anticipatory guidance. So we would talk about what stage might come next so that they were ready and prepared for that. It wasn't quite such a shock. And I think in my experience, it is really useful because, you know, if you're aware that some of these behaviours might eventuate when they actually happen, it's not such a shock, it's not such a frightening experience because you've been warned that something like this, you know, may well happen. So I think it's a really useful graph or chart to have in your desk so that you can pull that out. And it's also got those domains there, those stages, got a bit of everything to help you trigger what we've talked about, saying, oh, that's right, you know, I've got to ask about physical changes as well, or I might want to ask about any mood change as well. So a super useful tool. We know, if we can go into the next slide, Jenny, we know there are loads of next slide, Jenny. Loads of barriers to getting that diagnosis in stage 1. And a lot of that is around stigma. There's a lot of stigma around having a diagnosis of dementia. The older population that I see in my practice are always very fearful whenever you mention that we might do a cognitive screening or a cognitive assessment with them. It's always like, oh no, I remember those questions you asked me. And their fear is often around that, you know, they're going to lose all their dignity, their independence, the house will be sold, they'll be put in a nursing home, they'll no longer be able to drive. So there is a lot of stigma, and that really comes down to lack of public education and information. For both people with dementia and clinicians, that lack of a diagnostic test is really challenging, you know, because it's never got that 100% certainty. So that makes it really difficult. And for some people, particularly depending on where they live, it might be really difficult to even access a GP, let alone access a memory clinic or a specialist to get some support in that space as well. It's very similar for us as clinicians. As I've said, we've had very little education on dementia. There is no clear post-diagnostic pathway for us. It's not like diabetes where we can say, you know, here's metformin. We know metformin works for most people. You know, there are medications that we have. Do they work for most people? It's not quite so easy. And for a lot of us, you know, we want to be able to help our patients. And if we don't feel like there's a lot we can do to help them, often we would prefer to look after other things than, you know, turn our attention to perhaps the cognitive issues that we might be seeing. So we'll focus much more on their heart failure or their COPD, or because there's things that we can do for that. So lots of barriers, and we're all totally, you know, aware of those. So if we go into the next slide, though, I think it's important to think about, as Karen said, if we miss the opportunity to make a timely diagnosis, some of the problems that we're going to see that we might have a failure to intervene. So we might have the opportunity to look at doing optimization of everything else for the person so they can stay as well for as long as possible. There might be functional things, impacts changes that we can make around the house in terms of supporting the person. If you just do a few clicks for me there, Jenny, some of these will come up for us. That's it. Things about, I guess, as Karen was saying earlier, having some decisions around what you want to do. So getting the opportunity to appoint a power of attorney, make sure that you have got a will that's up to date and in place and that it's your wishes. Identifying someone who you'd like to be the substitute decision maker. Advanced care planning, we really like to be able to do that before we get to this point if we can. And just having the opportunity to look at, when we know that most people are going to end up in residential aged care, having a look around at some of the facilities. I remember I had a patient who, a psychiatrist, when I did a placement, actually had a patient who was a doctor actually, and the doctor had come for a follow-up appointment and the psychiatrist said to the doctor, "Oh, I heard that you went to visit the nursing home the other day. What did you think about it?" And he said, "Oh, it's a lovely, lovely nursing home. The nurses were nice. The rooms were really nice. But I just don't think my sister's quite up to nursing home care." So he hadn't actually realised that looking at the nursing home was for him. There can be some really dangerous decisions that are made. And I remember my dear old dad, who made a significant financial transaction before we had the confidence to enact enduring power of attorney, that really had a significant impact on he and mum's future. So people do make decisions when really, they can have some quite significant long-term consequences. And it certainly has an impact on families. I know we're a highly educated family. Some of us are medicos. It was very difficult navigating this space for us as a family. So it does have a huge impact when people aren't really clear about what's going on. So now I'm going to hand you back to Karen, who's going to talk about how we start approaching making a diagnosis of dementia. If we go to the next slide.
So what we do know is the diagnosis, there isn't that easy test at this point, but we do know that the bulk of our diagnosis is based on our history. And that might be not just the history taken from the person sitting in front of you, but hopefully as well, there might be some collateral history as well. Our examination investigations are really more looking at ruling things out and making sure there's nothing else contributing to that memory and functional sort of impairment. So history is absolutely key. So apart from thinking about our domains, our 5 domains, which helps guide our history, what we're going to do is give you a framework to help us with that diagnosis. So if you move on to the next slide, Jenny. So as a framework for making a diagnosis, and we're thinking again specifically about Alzheimer's and vascular dementia, there's 4 inclusion criteria. And this came from one of the geriatricians that we worked with early on, who really looked at the DSM criteria and tried to distill it into something that was easy to remember while you're sitting in practice with someone sitting in front of you. So the 4 things that you definitely need when you're making a diagnosis of dementia is that the poor memory must have a gradual onset. So if you were fine last weekend and this weekend, you're very confused, that's not dementia. It might be someone we watch, but it's not, we can't make a diagnosis of dementia when it's that sort of quick. So we want to see that gradual onset. We want to see worsening. So over time, whereas that mild cognitive impairment might stay the same, the dementia, we need to see that impairment worsening. It's got to be associated with a failure of function. So there's got to be significant impacts in that sort of daily life for that person. And we also want to see some evidence of cortical dysfunction. So when we're thinking about things like dysphasia, agnosia, and dyspraxia, dysphasia, you might see that in their sort of verbal fluency or word finding difficulties. So a lot more, doc, or looking at their family member that they've come with to answer for them because they just don't have the words There might be agnosia, and that's we're probably more familiar with because of the mini mental state examinations where, what's a pen or a watch, so that word actually naming difficulties. And then dyspraxias tend to be more not being able to, you might know what it is, but you don't know how to use it, or you can't demonstrate how to use it. And we see some of, again, those constructional dyspraxias when we're looking at things like the clock faces or the intersecting pentagons, and that sort of thing is another way of testing dyspraxia. And then for vascular dementia, we might see some other signs as well, but we don't need to see those necessarily to make that diagnosis. So you have to have all 4 things.
And Karen, what's an easy way to check for language fluency if you're just not sure?
Yeah, so one way we can test is actually, and it's in some of our cognitive assessment tools, but one way is actually looking at verbal fluency. So getting the person sitting in front of you to name for you as many animals as they can in a minute. So they name them, you write them down, or as many words as they can think of that start with the letter P. And what we see in that is for most people should be able to get to at least 12 or 14 or more words in that time frame. Somebody that has no memory difficulties, you'll find, and if you do it yourself later, if you write down as many animals as you can in a minute, what you'll find is typically you cluster things. So there'll be a cluster of farm animals and a cluster of zoo animals, and then maybe some African animals. So our memories work by retrieving in clusters. If we look at someone with dementia, often what we find is they might start with a couple that's okay, and then they might repeat that one again, or they might be is kookaburra an animal, and then there might be another random one, and then they just peter out. So that's a really easy way of testing for dysphasia, which is in some of the cognitive assessment tools, but you can just add it in yourself as well.
And it's quite interesting. I use that quite a lot, and you can really tell very quickly when someone has a problem once you get familiar with getting people to name all those animals or something starting with P. Great. Sorry.
So that's our 4 inclusion criteria. If we go on to the next slide, as well as those 4 inclusion criteria, we have 3 exclusion criteria. So we can't make a diagnosis of Alzheimer's and dementia today if we're in the presence of delirium. So if there is somebody with delirium, though, that may be someone that we want to put as a recall into our systems to watch, because that delirium itself suggests that their cognitive reserve is quite a lot lower. And they certainly may be at risk of dementia. They may have dementia, but we can't make a diagnosis in the presence of delirium. We certainly can't make it in the presence of other sort of organic causes, and that's where some of our investigations come into it. I had someone once whose TSH was 88, and not surprisingly, their cognition significantly improved as we treated that. Some of the medications that we give people also can affect their cognition. And then if somebody has a really significant depression or anxiety, we don't want to make a diagnosis until we've treated that as best we can. Because again, we know that sometimes we do see significant cognitive impairment and functional changes when somebody has a severe depression. So we need not only to have those 4 inclusion criteria, we've got to make sure that we don't have any of the 3 exclusion criteria in order to make our diagnosis. If we need to treat these things as best we can, we want to come back and recheck that cognition in 3 or 6 months' time. It's a good going delirium or significant depression or effects from organic causes may well take 3 to 6 months to really significantly settle down.
And why do we have delirium as a red flag, Karen, for someone living with
dementia?
Certainly
it does suggest that your cognitive reserve is a lot lower. So somebody that's young or that has no difficulties with their cognitive reserve is very unlikely to become delirious in the presence of a urine infection or constipation. Somebody whose cognitive reserve is very low, we may well see them become delirious. So they're really people we want to monitor cognition, because they may well have dementia already, or they may be significantly at risk of developing it in the future. So it certainly should be if you see any discharge summaries with delirium, you certainly want to stick it in your recall to reassess their cognition down the track.
Yeah, perfect. If we go into the next slide now, Jenny, thanks. We're going to introduce you to our patient, Anna, who is 75. Jenny will move the next slide in a tick. She's a 75-year-old.
I think we've lost Marita. Are you still there, Karen?
I am. So we'll meet Anna. So Anna's 75. She's lives alone. She's come in with her daughter Sophie for her flu shot, and normally she comes on her own. So that in itself should be something that just makes us think, maybe there's something going on either that's been happening or that Sophie's concerned about. So any sort of time people come with their families, it's always a bit of a red flag. She's got a fairly simple medical history for someone that's 75, which is nice. So just hypertension, some osteoarthritis, and she's certainly just on a couple of pretty simple medications. So just perindopril and Panadol Osteo. So we didn't talk about it before, but certainly one thing that we can watch out for if somebody's coming in with a family member is what one of the geriatricians coined as the head turning sign, where you ask a question and they immediately look to the person they're with for the answer, or they're merrily answering away and the person in the background is going, no, that's not actually true. So there's a soft, not an inclusion criteria, but something to keep an eye out for. Welcome back, Marita.
I don't know what happened there. That was weird. I felt like I was, when you're on the phone talking to someone, all of a sudden no one's there. So if we go into the next slide. Oh, it's my dropping out. There we go. So Anna is visiting her GP for her flu vaccine. Now, Karen, if Anna usually comes on her own, but she comes with her daughter, what sort of things go through your mind?
Yes, we were just speaking about that. So,
you don't have missed that, great.
That's all right. Certainly is just a red flag, that either there's been something acutely going on or Sophie might be worried about something for them to come in together.
Great. So if we go into the next slide, thanks, Jenny. We're going to actually watch the consult between the doctor and Anna and Sophie. And what we want you to think about, and you can write this in the Q&A while you're watching the video, if you can think about which inclusion criteria you might have seen Anna demonstrate. That's a bit of your own little cognitive test tonight to see if you can remember those 4 inclusion criteria, what you thought the doctor did well, or what strategies you used, and perhaps what he could have done differently. So if there's any of those thoughts you're having while you're watching the video, just pop those in the chat screen, in the chat box, sorry, not the chat, the Q&A for us, and we'll have a look at those. And hopefully Jenny's going to be showing us the video very soon.
I'm just checking. You are seeing the video, aren't you? In play mode? Not yet.
No.
And now?
Hi, it's good to see you.
I think it must be on another screen, Jenny.
Yeah, I thought I'd done something wrong. My apologies, guys. Let's try that again. Got everything ticked.
Flu injection. I think I'm a bit late, am I?
You are a little bit late, actually.
Oh.
Yeah, I was wondering,
I can't see it, Jenny.
Right, I'm going to do it.
It was there now.
Yeah?
Was there.
Yeah, it was playing.
Yeah.
All right, here we go.
Hello.
Hi, it's good to see you. How's things been going?
Look, I've come about the flu injection. I think I'm a bit late, am I?
You are a little bit late, actually.
Oh.
Yeah. Yeah, I was wondering, we sent out some reminders. I thought maybe you didn't get the reminder for the flu.
I can't remember getting one, no.
Yeah, well, that's great that you've come along today.
Yeah.
I haven't seen you for a little while. How have things been going?
Cutting back a little bit. My garden was fairly big, and I'm just sort of downsizing a bit on that because although I still love it, it was getting a bit much for me, so I'm cutting back on that.
And I just had a look through your file before you came in and noticed that your blood pressure medication were due a little while ago. Have you still been taking your tablets for blood pressure?
I think so.
Yeah, you take them in the evenings, Mum.
Oh, do I?
Yeah.
Right, yes, okay. But I've run out, have I?
Well, the prescription looks like you should have run out a little while ago if you'd been taking them regularly.
Oh, right. Perhaps I miss some sometimes. I'm not sure.
Well, it can be hard to remember, and there are things that we can talk about that might make that easier for you.
Right, okay.
Was there anything else that you were concerned about at this stage?
Well, we just had a little bit of a worry with the memory loss, like forgetting to take the pills, which we've just heard now. There's been a few incidences of leaving the stove on overnight, not realising that you'd turned the stove on.
I don't remember that.
No, I know, and that's the thing. There's been a couple of things that that you don't remember. Yeah. I don't know if that's normal at this stage, at age, but I just thought it might be worth a check
on some of those things.
Yeah.
In a moment, I'll take you around to see our nurse, and she can give you the flu needle, because that's the main reason why you've come today.
Yes.
Yeah.
And I'll ask Jane to also check your blood pressure and weight, like usual, just to make sure that everything's going along okay.
Right.
One of the other things I'd like to ask Jane to do with you while you're there is to do a real simple memory test to make an assessment about how your memory's going.
Yes.
Because it seems like, from what Sophie and you were saying, that you've been having a little bit of difficulty with your memory.
Yeah, I'm not sure about that, but maybe have the test.
It would be good, and you've always been very proactive in your health and want to keep on top of things. So that's part of that process of staying on top of things, if that's okay with you.
Yes.
Yeah.
Yep.
And then perhaps as part of that process of trying to keep on top of things while you're out with Jane, would it be all right with you if Sophie and I had a conversation about what she's been noticing for you with regards to
that's
your health?
fine. That's fine. Yeah.
Yeah, happy with that?
Yes, I'm quite happy with that.
Great, thanks for that, Jenny. We've had a few responses in there in terms of that Anna had come a bit late for her flu vaccine. We might go into the next slide, Jenny, when you get a chance. That her function had changed. She wasn't, doing the garden like she had been. And that she wasn't remembering about whether she was taking the pills at night. The stove had been left on as well, and she almost got a little bit irritated by that. And it was a gradual onset with worsening memory. So, Karen, anything else did you think came up in that?
Yeah, certainly some safety sort of issues around the stove. That's certainly something we need to, that from a functional side of things. She kind of answered that initial question in a bit of a random way. How are you going? Oh, I'm cutting back on my garden. So it didn't quite fit what the question was. So there was certainly a few just little flags going on. But I thought certainly the doctor did help use his, his technology, his program to identify that she was late with her pills, that she was late with her flu shot. So being able to use what we've got in front of us to help just identify some of those things that our patients might have is really useful.
Yeah. Thanks, Elsa. That's terrific that you could tell us that 3 out of the 4 inclusion criteria were met, but cortical function was not demonstrated. Well done. What did you think about the simple memory test?
It's not something I ever say. I tend to say I'm going to do some questions, or I might say memory questions. I really would hesitate to use the word simple, and I'd hesitate to use the word test, because I think as soon as you say something's a test, that just ups the ante and makes people feel more anxious. And it's not always simple. Sometimes I tend to say some of the questions might be really easy. Some of them might be really hard. Just give it a go. See how you go.
Yeah, I think that's a great approach. And I think it was also very important that he did ask for Anna's permission, keeping her very central to the process. She was the patient, asking permission that while she was out having her flu vax and seeing the nurse, that he could talk to Sophie to get a collaborative history, because of course that's where a lot of more information is going to come from, that collaborative, or the person who knows the person living with dementia. the most. So if we move on to the next slide, Jenny, and we just have a quick think about some examinations or office tests that we might like to do. I think Dr. George had mentioned a few of them. He'd do a blood pressure, he'd do a weight. What are some of the other things that you might think of in this situation, Karen, when someone first presents with some potential cognitive change?
Yes, I'm certainly thinking about blood pressure, weight. Again, are they, physically, are they losing weight, gaining weight? Is there anything different that we might pick up? I certainly might do a brief cardiovascular or neurological examination, depending on what other symptoms that they might have come in with. I might test the urine if I'm thinking they might have delirium. So somebody has mentioned doing a urine test. So really thinking about those exclusion criteria, which is really what we're doing when we're thinking about physical examination. And we might do an ECG if we found something like atrial fibrillation, or perhaps down the track if we're thinking about medication. And then, of course, there's the cognitive assessment tools that we can use.
Move on, and then we can move on to the next one. And Karen, are you happy to talk about cognitive assessment tools? Great.
So there's certainly a few. Many people are very used to mini mental state examinations because that's what's in most of the software. We do know that they're not great for particularly picking up people who are very highly intelligent. You have to actually, it's quite a bit before the mini mental is sensitive enough to pick that up. Some of the others, Mocha is probably more sensitive around that. We've got our RUDAS, which is really good for people where English is not their first language. So it's validated for use with an interpreter. Or for people who haven't achieved very highly at school, because it's much more, here's the shopping list, what do you do when you cross the road, rather than spell things, do some maths, that side of things. We've got our Kika, so both a remote and urban and a Torres Strait Islander validated assessment tools. So again, it's just a different way of assessing cognition that's more effective and validated for those different cultural settings. There's GP Cog, which is validated for use in general practice. In fact, I like using the mini Cog, which is really just the 3 short-term memory questions and a clock face. Again, that's also validated for general practice. So there's a few different things, types that you can use. It's just worth being familiar with the ones that you're going to use, and if your practice nurses are doing them, actually sitting and watching them at least do one, or making sure they've you've talked through how to do it, because we do find that sometimes getting our medical students or our practice nurses to do some of these testings, if we haven't actually told them exactly how to do it, may not be as accurate. So it might be that they're giving more prompts than they should do, or there's nuances with things like the Mocha that we need to be aware of ourselves. So, and there is a telephone one. I haven't played with that one yet, but they since COVID have validated a telephone cognitive assessment tool as well.
Yeah, that just seems a whole nother level, a whole nother layer of complexity, doesn't it? But I'm sure there's settings where it's is incredibly useful.
Someone's asked about the Addenbrooke. Yep. Not certainly one that I've used, mainly from a time perspective. I do think it takes quite a bit more time.
Yeah, I think one of our colleagues, Dr. Steph Daly, she uses that one quite a lot. She's got a cognitive clinic where she uses that, so it's a much longer process. Yeah. So I think from what you've said with that these cognitive assessment tools are going to help in terms of making a diagnosis, but they're certainly not diagnostic. So if someone scores 30 out of 30 on their mini mental, that doesn't mean they don't have dementia, does it?
No, in fact, one of my registrars only a couple of weeks ago had someone in their early 60s who scored 27 on her mini mental, and she certainly had significant history of concern. When my registrar did a clock face, it was really, really abnormal. And in fact, when she went on to do some other testing, it was certainly worse than what the mini mental appeared. So you'll notice that the mini mentals and any of those cognitive assessment tools do not appear in our 4 inclusion criteria. So you can have dementia and have what appears to be a normal score. You certainly may have a low score without having dementia. You might have, delirium or other, organic things going on. So they are helpful, but they certainly aren't diagnostic.
Great. I particularly like the GP cog because it's actually very clear step by step exactly what you need to do, and it doesn't take too long. It has a great little informant interview as well. But most of all, if we go into the next slide, one of the reasons I love it is because it tells you about the investigations you need to do. So again, you don't have to remember all the things that you want to be thinking about. But when we're coming to our investigations, which follows history examination, we're thinking really about those reversible causes. If anyone wants to throw any investigations they would do in the Q&A, based on thinking about those reversible causes, feel free. But if we just pop the next slide up, just in the interest of time, these are sort of what's recommended in terms of routine investigations. And then on the right-hand side, they might be for sort of more specific patients. But I'd encourage you to look at all your health pathways, because certainly different referral services may ask for different tests to be done before you do a referral, if that's what you're going to do. The whole diagnostic space of Alzheimer's is changing with the advent of access to Medicare funding for PET scans, functional MRIs, but that's really outside of the GP space at this point in time. So we would still be advocating to do a CT as a baseline investigation. So we're going to move back to the next slide, because Dr. George has done all of that with Anna, and Anna's come back now for her follow-up, and he's found that her examination was normal for her age, that her blood tests and her CT brain were actually normal for her age. Her mini mental score was 23, but again, that's sort of probably confirming what we're expecting. But if it had have been a lot higher, that wouldn't be a reason to think, oh no, she can't have dementia. He was able to demonstrate that other criteria, Elsa. So she did have a dysphasia, and she also had the word finding naming difficulty. And they did a geriatric depression scale, just thinking of her withdrawing from the garden and not going out to bridge so much, just to make sure she didn't have depression, and that came back as normal as well. So if we go to the next slide, thanks, Jenny. We can see that from our 4 inclusion criteria that Anna certainly has met those criteria. She had a memory that had been poorer than previously, and it had been over months, not days or weeks. It was getting worse. They were noticing that she was increasingly forgetful. There was some failure of her function with her gardening, her cooking, and her socialising that had changed. And she did have some of that cortical dysfunction as well. So if we go on to the next slide, which will have our 3 exclusion criteria, she wasn't delirious, and her examination and mental health was okay. So if we go into the next slide, we're just going to ask you, and just you can put a Y or an N into the Q&A if you'd like, just to say, are you feeling confident now after all of that she has dementia? Very confident, somewhat confident, or not confident at all? How would you be feeling at this stage, Karen?
I'm certainly feeling very confident based on our inclusion and exclusion criteria. We've certainly got a number of others feeling very confident as well.
Yeah, that's great. Good. So I think we were all at this point hopefully into at least the somewhat confident that she has met those inclusion exclusion criteria. And so that really brings us to the end of tonight's session in terms of getting to that point where we're thinking about being confident that this is what Anna has. So going back to our take-home messages, so we're going to end with the beginning in mind now, that hopefully you got a clear understanding that dementia is more than a memory problem, that our cognitive assessment tools are not diagnostic tests. They help us, but they're certainly not diagnostic. And in many situations, a person's GP is able to make this diagnosis and look at initiating post-diagnostic care. So with our next session, we're really going to move on to how we might deliver that diagnosis and what we might do to start the post-diagnostic pathway for Anna and Sophie. So hopefully you can join us for the next session, and we can talk to you about how we might approach that.
So Marita, I might just jump in and give you two a rest. And just before we hand over, just a quick talk about some of the resources you can access on the Dementia Training Australia site. There is a GP landing page. It has a scrolling function, so you just scroll down to access a whole range of resources. We also have a podcast. In fact, the team have recorded 2 seasons and the third one is in production as we speak. You can access these podcasts wherever you would access a podcast. Highly recommended that you jump in and listen to one. You'll become addicted, and that's what you'll be listening to for the next little while. There are some optional CPD activities. So for the GPs in the space, you will receive in the follow-up email 3 activities that you might wish to complete: driving assessment, identifying mild cognitive impairment, and implementing a brain check. They can then be used to self-report, and you will get education activity and reviewing performance hours for those. What else have we got there? Yes, don't forget that the next session, as Marita said, we're super keen for you to come along and hear about the rest of the journey. So I'm going to stop sharing now, and we're going to hand over to Dr. Precious Maguire, who's just going to share a few slides and introduce the pathways. So over to you, Precious. Yell if you need anything.
Okay, it's here. I'm excited. Good evening, everyone. So I'm going to be really quick so everyone can get on with the rest of their lives. So this is Health Pathways. It is made to be used in the consultation. So with this, it's a very simple homepage. You can search for pathways, and these are all the older adults' health, or you can use the bar at the top to put in as a search. It has all the latest news and alerts, all the pathway recently that have been updated, and then lots of resources. Now, every single page has a send feedback button. Now, if you don't know about Health Pathways, then you can register. So either you get on to melbourne.healthpathways.org.au and you will come up to this screen and it says register now, or via the QR code, or you can send an email at info@healthpathwaysmelbourne.org.au. Now, if we're looking at Anna, and it's a different photo, so hopefully she lives near the beach, hopefully in Queensland, what we want to look at is, how can it actually be used practically? So when Anna presents, we've seen the consult. So we've seen sort of how the GP has worked through the process. Now, we generally, this has come in for a flu vax, so she's probably had a 15-minute appointment. And practically, you need to really look at what can be done in that time. And very important, like he did, to look at what Anna's concerns were, which was having a flu vax. Then what Sophie's concerns were, and then what our concerns are, and what we can actually, get done in that time. So how can Health Pathways work? So from what we've looked at Anna, there are multiple older adults pages that can actually help. Not just the cognitive impairment, but carer stress, elder abuse and neglect, and then all the referrals. So this is, and this will be the fun part, this is good. So this is the pathway as you would see when you got on. So this is a statewide pathway. So right across Victoria, wherever you live, this is what the page will look like. All of the pathways have a see also, if there's relevant pages. They have background information, which does look at the more statistical sort of information. Then every pathway has an assessment, management, referral, then resource section. So with tonight, we've been talking about assessment. And as you can see right at the top, cognitive screening is not diagnostic. On the pathway, we also have looking at dementia prevention, because there's lots of information out now that treating cardiovascular risks will actually lower your dementia risk. Really important to make the timely diagnosis. And then, as has been said, there is, if I can get this right, most of the diagnosis is based on history. Let me see if I can get this to work. It's a lovely little animation. I'll try not to stuff it up. And when we're looking at history, we're also making sure we have a collaborative history. We're assessing the different signs and symptoms, and that's looking at cognition, looking at behaviour, looking at the psychiatric symptoms, then also looking at other neurological symptoms and function on ADLs, and then carer stress. Again, the criteria for diagnosis of dementia is there, high-risk features, and then the differential diagnosis. Now, this is my favourite bit. I love this little table that's really simple and helps me work through and decide, and exclude delirium, exclude dementia, just from a very simple sort of focus. Then we go on to, I'll just try and stop that, examination, and where we've actually got the focused neurological examination that you can go to look at, the depression scales, the rest of the physical examination, and then we will need to change that where it says screening, but it's a validated cognition tool. And all of the tests all the tools that were discussed tonight are actually present there. So instead of having to go to multiple different places, what we've tried to do, and what the real big advantage of Health Pathways is, it is all in there. So it's not just a resource, it's actually a living document that can be updated, can be changed as needed. We then look at investigations, and that includes all the list of bloods we talked about and the CT, and also consider hearing and vision tests. Now, we get the patient back like the GP did, and when you've got all the investigations and you've got all the tests, then you can make a decision about what you think the diagnosis is, because really important, because that will then impact on management. Now, these are the latest statewide pathways. So we've talked about cognitive impairment dementia, BPSD. I saw there was a question regarding BPSD in the chat. So there's a whole pathway on management of that. There's the 5-minute neurological exam and the pathway for medications for dementia. And then all referral pages and resource pages have been updated. There is a Melbourne specific dementia consumer resource that has been made for patients and their families to talk about, what to expect in the dementia journey. And it goes through all of the different things that maybe there are questions to talk to your doctor about, and then goes all the way through to supports. There is also a dementia directory that has been developed that's a searchable resource of all the local support and referral services. This is the list of older adults pages. And as you can see, there are clinical pathways, including residential aged care, older adult referrals, and then lots of resources. These are other pathways that aren't specific, but are related. So fitness to drive and occupational therapy driver assessment. You've got other referral ones like allied health and nursing. You've got resources like death certificate, community transport, BAD. you've actually got a full suite of palliative care and end-of-life pathways. You've got the medicines and resources that could be useful. Now, I've been very brief so everyone can go home. So what's next? Between now and next session, if you haven't registered, please register for Health Pathways. Go on, have a look. And I really want you to send feedback on that feedback button on the pathway that we've been sort of working through tonight. And I want you to say whether it's usable or not. I want you to say if there's anything that's not there or things that are good there. So just have a look and provide feedback. And last but not least, after the second meeting, about mid-August, you will be sent a survey, and there's a lovely carrot there for all the GPs. So there'll be $100 voucher up for someone who responds. So it's only 5 questions about the pathway. So that's just something to look forward to. So thank you very much. And if there's any questions, please don't hesitate to let us know.
If you've got registrars in your practice, Health Pathways are just awesome. Well, we use the Brisbane ones all the time.
Thank you.
Thanks so much for doing that, Precious. That's a really good way to kind of really reinforce, you know, how you can use it directly to the case. So hopefully people will have a look at all those pathways. I don't know how people manage without the health pathways in general practice these days. There's just always so much to know and so many things changing all the time.
Well, if that's it from our presenters, I might conclude the session. So thank you all for being a part of today's session. It has been an absolute pleasure to have you all here tonight. I hope you've taken away some valuable insights. I'd also like to extend a special thank you to our exceptional presenters for their fabulous work. For your accreditation and so that we can further improve these education workshops, please take a moment to fill in the event survey. You can do so now by scanning the QR code on your screen. And also at the end of this session, the survey link will appear on your screen. Your responses are highly appreciated and greatly valued. By participating in tonight's RACGP accredited activity, you'll receive 1.5 hours in educational activities. Northwestern PHN will lodge those hours through the RACGP on your behalf. Tonight's session is one of 2 in the Demystifying Dementia series. Session 2 is on post-diagnostic care of dementia in general practice. This webinar is also an RACGP accredited activity, and by participating, you will gain 1.5 education activity hours. Scan the QR code on the screen for more information and to register yourself for session 2. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen tonight, in addition to other relevant resources. You will also receive your certificates within the next 4 weeks of this session from Northwestern Melbourne PHM. Thank you all for your time and attention tonight. That is all from us, and have a wonderful night. Thank you all.